At the start of April this year, Chris Bown moved into one of the hottest seats in Jersey's civil service as he took up the role of Acting Chief Officer for Health and Community Services. As the top-ranked officer in the department, Mr. Bown has a number of important matters in his in tray. These topics include an attempt to achieve a turnaround in the department following allegations of bullying, lengthy waiting lists in the General Hospital, and ongoing issues around bed blocking as medically fit patients are unable to be discharged because they have no onward care arrangements. He is also charged with working alongside partners in government to deliver the island's new hospital project. In this episode of Bailiwick Podcasts, I, Tom Innes, sit down to talk to the experienced administrator about the first third of his 12-month contract at Health, and find out how he intends to make a positive difference over the remainder of his time in Jersey. Good morning, Chris Bown, Chief Officer, Health and Community Services. Thanks very much for coming in to talk to us.
Pleasure.
We're just starting off. I realised that you're around 4 months into your role as interim. You spoke very positively and honestly when you started the role. It's clearly a challenge that you were up for and looking to make a difference. You're around a third of the way into your fixed term contract. How are you feeling now? How has the challenge been once you've actually been working on it for these months?
Well, as you say, I'm 4 months in. I've had the privilege to meet many colleagues, both in clinical and non-clinical teams throughout the service, whether it's in the hospital or in our mental health services or in community services. And one thing I really do want to say is to impress to people how committed those people are to providing the very best of health services and community services and indeed social care to the people of Jersey. I've been repeatedly impressed with that commitment wherever I've been. And I think there is a recognition across HCS that things do need to improve. That the Hugo Maskey-Taylor report is something that we've focused on, particularly in strengthening our clinical governance across HCS. We've put a significant priority on cultural change, and I think I've been quoted in the media already about my zero tolerance to bullying and indeed discrimination, and that continues. We are obviously at the early stages of making cultural change. Cultural change is not something that happens in 12 months, particularly if a culture has been embedded in an organisation maybe for decades. But we continue to see early shoots of green shoots of improvement. We have started to strengthen the clinical governance, improving, for example, our processes of incident reporting and how we learn from incidents to ensure that things don't happen again, and that we can build on the improvements that we're making. We are starting to focus very much on recruitment and retention. Recruitment is a real challenge, as I know it is across Jersey, but we're very much focused on increasing the numbers of nurses and doctors and allied health professionals. And of course we have a big financial challenge that I think I've spoken about before, that we need to plan and prepare for. So we are starting to see, I think, I am, and the change team that were working with me, some early improvements, but there's clearly a long way to go. But also to say that I also see areas of extremely good practice, excellent care that's been provided to our patients, and we only need to sort of look back at the then PICA survey of what patients felt about the care that they received in HCS, which I think was probably last year. And to be quite honest, if I was a chief executive in the National Health Service, I would give my left arm to have a report like that. It was outstanding. So I'm very pleased to see that, and I can see why the patients have said that, having spent 4 months working with colleagues across the service.
Great, thank you. Quite a few bits to pick out of that. Certainly, you talked about some green shoots and early signs, and while making the point that this isn't a quick exercise, is there early evidence that some of the negative approaches, some of the aspects, the bullying, things like that, are going to be wound down, eradicated, eliminated? What progress there?
Yes, the first step, of course, is people's willingness to speak up when bullied or discriminated against in any way. We have our Freedom to Speak Up Guardian, who's now in place, and people are using her. I also meet on a regular basis on a one-to-one with staff that want to speak to me directly about their experiences of working in HCS, and I've met many colleagues who have had poor experiences and then are able to look at how that happened and what we need to do to address that. So the first stage is speaking up, so we can see where those issues are and tackle them head on and face on. We know that there is discrimination that takes place, racial discrimination, not just within the organisation, but by patients and visitors. That is an unacceptable situation from our colleagues from overseas, who we depend on, that provide high quality care to residents. And again, that is something that the senior leadership team at HCS has discussed, and again needs to be addressed head on. No point pretending that these things don't exist, otherwise we'll never deal with them. So I think we are starting to see that, but we know that cultural change will take, as I said, time to achieve. It doesn't happen overnight.
And looking at your senior leadership team, the people who you're looking to deliver your message down the line, because clearly you've got thousands of people in the pyramid beneath your position. Do you think that do you get a sense fairly on in terms of when you're talking to people that this is a person whose attitudes can change and they can become the sort of leader that I want and I need for my department, and other cases where you think this is too deep rooted, this is someone who's been here for decades, who is too entrenched in their position, and I can't have on my ship?
Yeah, I think in most cases, as with any organisation I've worked in, most people want to come to work and do a really good job, and I see no difference here in Jersey. I think people can change, and some, as you say, can't. I think one of the things that I've been looking for in dealing with this is evidence, and there is much anecdotal comment about things, but when you're dealing with things professionally, you need proper evidence, and if there's evidence that there is bullying, then that obviously needs to be tackled, but we often just anecdotal evidence is not enough to pursue these cases. But there is a mix, but say most of the people I meet are keen to see change happening and want to be part of that. And I think when you look at, and it's obviously often the focus of the media, politicians and the public, understandably, as it is in the UK and many other jurisdictions, about how many managers. That comes up a lot, and one of the things I was told when I arrived, that there were too many managers in HCS, and so I've undertaken a review, which I took to the State's Employment Board, recognising the context of 3,000 people, over £250 million turnover in healthcare, and the range of things that leaders have to do. It's not just about providing acute community and mental health services, but importantly we have to serve the democratic process of Jersey, and ensuring that we're held accountable. We have to commission services, many tens of millions of pounds worth of services for mental health placements, tertiary care in the UK, and we have to ensure that Jersey people get value for money and the biggest bang for your buck in those services. But the proportion, the ratio of managers to the total staff is about 1.7%. Most of our leadership positions are actually clinicians, whether they be doctors, nurses or allied health professions, but those that I think that are often the focus of media and public attention is about 1.7% of our total workforce. So it is relatively small, and certainly myself and the change team would be concerned that with the major change programme that we're facing, that we've talked about before, that we actually are undermanaged as regards to being able to drive that through successfully. And clearly those are further discussions I'll need to have with the team and with government and with the health minister about how we ensure that the momentum that has been put in place with the change team continues, because we are looking at a programme of transformation that is certainly longer than 12 months.
Sure. And will you be, I'm sure you've got plenty on your plate for this week and this month and the immediate future, but there also has to be an eye on the future and at some stage in not too far into 2024 there'll be a new permanent appointee. What is that something that other people are worrying about while you get on with the day job, or are you very involved in that?
I spend a lot of time doing the day job, and my view is that I need to ensure that we've got a programme of change in place and that foundation is in place, that anyone else that comes in can pick that up and run with it, and that we maintain that momentum going forward. Certainly, I think that the overall programme will continue for some years. It shouldn't be dependent on individuals. We should put in place a programme that can be delivered by whoever's in place. And I say most of my time is now spent focusing on that change. But we know we need to look into the future. We need to look at health funding for Jersey. It's a real challenge. That the financial recovery programme, which I'm sure you'll hear more about over the coming months, is a big challenge, not just for HCS, but I believe for Jersey as a whole, about how it funds health services. So those strategic issues and often those political issues are things that we do need to tackle. But as I say, the development of our clinical services is another really important area. I want to see improvements in maternity care. I want to see a reduction in our waiting lists. So whilst waiting lists were increasing pre-pandemic, clearly post-pandemic we've seen a significant increase in our waiting lists, and including those for diagnostics. We have unacceptably long waits in MRI and in ultrasound, for example, where there's a real focus now on how we might make those reductions. So waiting list reduction is important. A whole range of issues that we just need to keep the momentum going to ensure that Jersey and Islanders get the very best and the best health care that they deserve.
And I imagine it's difficult to put a date on it, but we're a year into the new government, and rather more recently, 4 months into your own stint. Can people look forward to seeing the waiting list start to come down this year? Is that realistic, for example?
Yeah, I think we'll probably see the biggest changes in the beginning of next year. We're looking at a number of different options because of the limited capacity we have, either physical or with workforce, that we bring workforce onto the island to help us reduce waiting lists, or indeed offer opportunities for islanders to be operated on, for example, in Southampton and other places. So we've been given additional resources by the government to do that. So we're now in the process of procuring those services. So I think the real impact we'll see at the beginning of next year. As regards to the overall programme, from my experience and that of the change team, to get us to where we will all feel very pleased and satisfied we have a service that islanders deserve. It's a 3-4 year transformation program. Now, of course, we'll see improvements on that pathway towards that 3-4 year position, but it is not something that's going to change in 12 months. The situation is such that it does require sustained effort, and that's no different to other health systems in other jurisdictions that have the same challenges as we do.
And you were originally engaged here as part of the change team before taking up your current role in April. Is the what change or what focus now is there for that change team, and do they have a wider remit? Is it there were originally some quite serious allegations that caused that to be set up by our former chief executive. Where is that process got to now?
Yeah, the change team have remained focused on the things that they need to improve. So our medical professor, our chief nurse, are focusing obviously on clinical governance and clinical improvement. Our OD and HR expert has been focusing on cultural change and recruitment and the need to improve recruitment. Our financial recovery expert is working closely with me and others on, and indeed the Treasury, on establishing a 3-year financial recovery programme. So the focus has remained as was. Obviously things emerge as you're here, and the different things come up that we need to pick up and address. But the initial objectives remain sound.
And you took some of the strands of that. HR is one example that in over the past decade there's been a shift primarily from the department to a centralised HR function. And now some suggestions that it may come back in the other direction. What's your view on that, and whether it's best handled within the department or centrally?
It's a controversial question, but I've always felt since I arrived that HCS needs to have a much greater control over its recruitment pipeline, and maybe it's because I've been used to that as a chief executive, having in the UK, for example, having that direct responsibility. But equally, you have to remember that we're operating in a global health market where there is significant shortage. And often sitting talking about recruitment, we could be in South Africa, China, Belgium, the United States, New Zealand, and we'd be having the same conversations because the global shortage in healthcare professionals is something that we're just experiencing on the island. So, this isn't just an issue of where HR sits. This is a significant challenge for all health communities in all jurisdictions. There are shortages of sonographers, for example, which are the people that operate the ultrasound system, and there's problems in the UK recruiting them. There's problems all over the world recruiting these people. So it's not unique to Jersey. So I think we often look at our vacancy rate, which is high, but equally it is no higher than many other organisations in other jurisdictions, and it's often driven by just a general shortage of professionals.
Sure. The challenges exist here and now for staffing a single site hospital. You can probably see where I'm going on this. We're moving towards a multiple site option for healthcare. That seems to a lot of people to create additional challenges. How worried are you by those?
I would say it does create additional challenges, but equally not having a new hospital at all would equally create difficult challenges, and I think we are where we are. We need to move forward. We need to plan for where there's a need to duplicate, and that's not in every service, but there'll be certain areas where we need to do that, and we need the appropriate healthcare or recruitment strategy and plan to ensure that we can staff those areas. To me, wherever I work, it's never the money, it's always the people. And getting hold of people is going to be the challenge. But I think, we're able to sell the fact that we're going to have a lovely new facility, both as an acute hospital and ambulatory, that we should start very much attracting professionals to the island, not just saying it's a lovely place to live, which of course it is, and we spend quite a lot of time, I think, showing the beaches and how great they are, and that's perfect and lovely, and people do come. We actually have to focus as well on what it means to be a health professional in Jersey. What are the opportunities for training, development, working in multidisciplinary teams, that we are an organisation that is going places, that we want to see significant improvement, so we're outstanding in the way that we provide healthcare. So I think we have a number of opportunities with the new facilities to be able to use that to attract staff to Jersey. And despite the challenges, I've always said that the thing that made me accept taking on the Interim Chief Officer role was just the opportunities that exist for improvement in Jersey. You know, we are a small community. You know, we have opportunities to improve how we integrate healthcare between primary and secondary care and community care and mental health and social care. And in some ways, if we can't do it in Jersey, you can't do it anywhere. So to me, it's a very exciting opportunity, but it's not without its challenges, as we all know.
And looking at some of those, and perhaps getting into some of the more operational matters, they're things you have a high level role, but I'm sure there are certain key topics that come up. You spoke to the scrutiny panel a couple of months ago about the new electronic patient record scheme, which had gone incredibly well, I think, with the words that you use. Feedback we've had from inside the hospital is that it's taking doctors and nurses 2-3 times as long to do the work that they need to do. Are you not getting that sort of feedback? Because it seems quite at odds with what you're saying.
It does, and I suppose incredibly well is relative compared to many other EPR, electronic patient record implementations. It has gone incredibly well. There are always issues when a new system's introduced. Remember, this is the start of a 4-year rollout of new technology in HCS. It is certainly strengthening our governance and data safety and patient confidentiality. We're far less dependent on paper than we were, and you're right, it is taking in some cases clinicians and others a little bit longer to operate, and I think that's the balance between the strengthening of our data safety, the strengthening of our governance does sometimes require that to happen. That's not unusual, but I think on balance, this system is far better than the system that we had before, and I do accept, and there are issues, and we try to address each one as they come along. We have a clinical chief information officer who is a consultant, a medical consultant, who is working with us and working with the team that has implemented it. So you're right, there are challenges with it, but we're in month number 2 or 3, I think, of its initial launch date. So it's early days, and one would expect a whole range of things that would emerge that we need to sort out. But yes, no, I totally accept that this isn't smooth, but I don't think I was ever expecting it to be smooth because I've never experienced one that has. But in relative terms, I think we've made significant progress. That's not to say that there aren't things that we need to address.
And you've talked about the sphere of the health department and the thousands of people within that fall directly under that umbrella. There are also health operations in Jersey that are in the third sector that are outside of the department's immediate control, but nevertheless have a big impact. I'm talking about the third sector care for people when they've come out of hospital, which is still having, as I understand it, a big impact on the department in terms of bed blocking. You have patients in hospital who are fit to be discharged but have nowhere to go, and that's causing difficulties. Can you do anything as Health and Community Services to work with the third sector to make things easier for them so that they can take your patients, to put it bluntly.
Yeah, you're absolutely right. The third sector is absolutely essential part of the whole patient pathway, as we would call it, and certainly if you're providing an integrated health service, then you can't do that without the third sector, whether that's the hospice or a care home, or indeed without the independent sector, without the private sector. We have to all work together to do this. Typically, we would have a ward's worth of patients that are probably medically fit for discharge, that would be better not sitting in an acute hospital. It's not where people really want to be. But we are constantly working with our colleagues in the other sectors to see how we can improve that. Often it's to do with investment, and in debates around future investment in the third sector, in community care, are important debates that will be ongoing and obviously part of the government planning process to look at how we can strengthen out of hospital provision.
And is it at the discussion and analysis and looking for possible solution stage now, rather than having solutions identified and being able to put them into practice? It's another of these longer term projects.
Yeah, I
right?
think it is longer term. There are some immediate things that I believe that the third sector are looking at and talking to government about, but we have to have something that's sustainable. When you look at the longer term issues around the numbers of beds, for example, that are being provided in the new facilities for the new development, that we're increasing the numbers of beds, recognising step down, etc. But the solutions are never easy, and in some ways, if there was an easy solution, we would have done it by now. So, and that can be also linked to recruitment, the ability to recruit healthcare assistants to work in care homes. Not an easy issue, and one that is faced, certainly by the UK, but other jurisdictions as well. We're not, again, unique in having medically fit discharged patients sat there waiting to go home. And I say, it's just not good care. We shouldn't be doing that, and we've got to find a solution.
And you mentioned again on the new facilities, and we're back onto the new hospital. I realise it's not your responsibility or your department's responsibility to build a new hospital. That's something that colleagues in other departments are directly charged with. But nevertheless, there's been a series of chief executives, both permanent and acting, who've been hoping to get this project off the ground. Are you driving very hard with the other departments and with the ministers, the chief minister, the new chief executive, when he comes into post in a month's time, to try and would you like this to be on your watch, that we actually start this project rather than talk about it and delay it and what have you?
Yeah, no, I don't think, in some ways I don't need to push it, because the push and the drive exists from the Chief Minister, the Infrastructure Minister, the Health Minister, and indeed what I see, the Council of Ministers, to get this moving. And we are, I suppose, as HCS, the client to the infrastructure team. So we are responsible for supporting the functional content of the buildings and how that's going to work. But there's huge commitment to moving forward. And I have to say, from what I've experienced, that I'm pretty confident, very confident actually, that we will make some progress soon. And of course the start will be when we start to demolish the vacant buildings at Overdale as part of the first stage of the development. And we're already moving our services from Overdale to the Enid Kennevay new hospital or healthcare centre, and patients are starting to be seen there. The full opening of it will be sometime during September, but I've been obviously there a number of times, and it is a fantastic facility. Certainly the quality of accommodation is far better than we see in Overdale. It's very modern, bright. The rooms are certainly the same, if not bigger, than the rooms that we have, much bigger than the rooms that we have in Overdale. So I also recognise, of course, there's concerns about its location and where it is, and I think we'll have to just see what happens there. But I think that's a very positive step in the right direction. So I'm very confident that certainly during my watch we'll start to see the start of that building process.
And just switching geographically to almost to the other side of the island, I'm talking about Clinic Pinal and the project there. That's clearly going to be part of this this project in the longer run. How much of your focus is on the projects that have been happening there already and will happen in the past, because that's an important part of it, obviously.
It is, and I say our team's focus has been on all the developments that we're seeing, both sort of the here and now, but also the future. So the healthcare estate is important, but I think let's just never forget, of course, the healthcare estate is not the only thing that we need to worry about. And I have seen in my career some of the best internationally renowned services provided in terrible old Victorian buildings, and I've equally seen in other parts of the world stunningly shiny new healthcare facilities with appalling healthcare being provided from them. So buildings don't solve the problem in that respect. It goes back to the point we were talking about. We need to recruit, we need to get people in, we need to have strong clinical governance, we need to have guidelines in place so that we know that we're providing evidence-based care, which sort of relates back to the Hugo Maskey-Taylor report. So the buildings are important, certainly they are, but on their own they don't provide a good healthcare system.
No, sure. One of the other things that we've had in the headlines recently, and again just last week, is the report into rheumatology patients and how the admission that it's not just rheumatology patients that may have been affected by potential misdiagnosis, and that investigation is now going into different areas. Which areas is that going to be heading in, and what stage is that investigation? Because it seems to be getting wider and wider, and we don't yet know the full scale of it. I don't know whether you do.
Yeah, well, I think I need to be absolutely clear here, and I think we have tried to correct perhaps that misunderstanding from what the Minister said, is that we are extending the scope of the audit, but only to those patients that were seen by two doctors prior to 2002. So this isn't extended to all departments within HCS. It's extended to the practice of those two doctors. So that we need to be clear, this isn't about a widespread problem in HCS. We're just extending the audit to look at the notes, because the first audit indicated that that's something that would be sensible and prudent to do for patients. So it is still it's still I say around those two individuals and not around the whole of HCS or indeed other departments in HCS.
And the date you mentioned for those doctors to have seen patients who would then be within scope?
That's before January 2022.
Okay, that's fine. And we've so those, it won't be as simple as saying, oh, it's going to move into this sphere or that sphere. It's more related.
I'd say it is to do with the notes of patients that were seen by those two consultants, and it's not. Please be clear, it's not about other departments in HCS.
Sure. There are currently a number of consultants who are not working. They're suspended. They're still on the books. They're being paid. The interims are having to be, or locums are being brought in to cover their work, and some of these situations seem to go on for years and years. Is that a frustration? Are your hands tied by HR procedures that you'd like to make quick change and quick decisions, but you're not in a position where you can do that.
Well, I think obviously I can't comment on individual cases. That would be completely inappropriate. And again, there are processes to go through, both from HR and indeed legal processes if that's required. It's only fair and right that individuals that have been suspended or excluded, that they have the opportunity to put their case, and there's a whole process that you go through. I would like to see the process, particularly as it relates to doctors, which tends to be much longer, and that's no different, say, than the UK, to be a lot shorter than it is, because I don't think it's in the interest of the person who's suspended and our duty of care to that individual, or indeed the organisation, or indeed financially, ultimately, that continues unnecessarily. But I think we have to recognise that in the cases, and typically in these cases, they are always complex. They always require full and proper investigation to ensure fairness, an independent investigation, not through HCS. And that does take longer than perhaps many of us would desire, but we have to ensure that due process is followed to get to a conclusion.
And just finally, you touched at the beginning, and it's clearly something you're very keen to stress on, the excellent care that continues to be provided by the staff in the hospital, and the positive results of the PICA survey and other feedback that you had. There are long-serving members of health staff leaving every year. They've done their 25, their 30, sometimes up to 40 years service, and great knowledge and assets are leaving the business as the passage of time it comes to us all. Is there an input of new talent who are going to take up the role, or is there gradually a drain of this experience out that may leave the department vulnerable?
Yeah, I guess generally, if you look at the numbers, the sort of output and input sort of balances itself, but it keeps the vacancy rate sort of remains the same. But of course, when you lose an experienced person after 30 years, it's unlikely that you're going to get someone from somewhere else who's got that 30 years experience. So training and sort of, as people say, growing our own is important. But as I say, there are excellent people that obviously retire and want to enjoy themselves at the end of a very long and dedicated career. So we do need, it goes back to the recruitment. In fact, this morning I met with a number of staff that have been put forward by their colleagues, people that have done outstanding work, and that we should celebrate the work that they've done. And I met with those colleagues this morning. We were hearing how, from an admin person in the breast screening unit, how we've reduced post-COVID the backlog that we've seen we've been waiting for scans, and these sorts of things are happening everywhere, and of course we don't often hear about them in the media, do we? And I often feel that staff in healthcare, colleagues in healthcare, tend not to come forward with the things that they're doing, because they see that as just the sort of BA, business as usual. This is what I do on a day job. But to you, me, and others, when you look at what they do, you think, wow, that's amazing. So they often underplay, and I think that's why it's always, when I talk to communication colleagues, very difficult. People don't come forward with these fantastic things they're doing, because they just see it as normal. They don't see it as requiring sort of praise. And I see that in the last 4 months. I've seen that in bucket loads, where people are doing an incredibly good job. Now, that's not to underplay the fact that we still have our challenges, because you and I know that we do, but it's not everywhere, and I would like to again sort of finish, I suppose, by praising the staff that I've met over the last 4 months, and indeed the staff I'll meet as I go forward.
Brilliant. Well, Chris, it's been very good of you to come in and talk us through it. The impression sometimes that nothing's happening in government in August. Well, here we are in the middle of August. We're here working, and you've obviously got the focus on that, and hopefully in another 4 months or so's time, we could get an update from you then as to how things are going. It's always interesting to hear from the top what the situation is. So thank you for coming in.
Thank you.
Thank you to Chris Bown for coming in to speak to us. We hope that he'll come back and update us via another podcast later in the year. Don't forget to visit bailiwickexpress.com or pick up a copy of your local JEP.